This is QD Clinic brought to you by RheumNow.Live, a great meeting in Fort Worth. Check out the faculty list. It's on the website, RheumNow.Live. And this is the last week of discounted registration. So you have until the end of the week to save a lot of money and come to Fort Worth and enjoy the meeting. My case I'm going to discuss today is called the Tophi Guy. This is a 68-year-old gentleman who comes to me with an acute attack of gout that had been going on for almost 2 weeks. This was in 2017. When I saw him, I was impressed by his tophi, which, to say the least, were voluminous, gobs and gobs of lumps and bumps over the back of his hand, on his Achilles tendon, on his elbows, on his knees. The tophi were grapefruit size. On his elbows, they were easily pool ball size, if you will. They were just gigantic. And he'd had a long history of gout, not treated for many years, and tried to treat it in the last few years. The problem is he's got all the comorbidities. He's got really bad hypertension, AFib, multiple hospitalizations for CHF. He's had a defibrillator. He's had a bypass. He not only has had hyperuricemia, he has COPD, sleep apnea, and a number of other things that are probably not germane to the discussion today. So we treated the acute gout attack. At the time, he was already on 300 of allopurinol. I raised him to 450. At the same time, I gave him some steroids, and he came back in a few weeks. He was better. Interestingly, his labs showed he had a creatinine of about 2.5. He had a uric acid that was around 3. It was actually really low. His CRP was very high. His sed rate was also very high. Yet he clearly had gout. We did an ultrasound that showed a double contour sign with stippling and beaded urate deposits being seen. Synovial fluid aspiration was chock full of MSU crystals. The aspirate was milky, clumpy, kind of unlike anything you'd ever seen before. So the question was how to treat him. We talked for a long time about aggressive urate lowering therapy, maybe combination therapy. We talked to him about the use of pegloticase, which may be the drug that was designed for him. Ultimately, he went on pegloticase. He was on pegloticase for about 8 weeks, took 8 milligrams as an IV infusion, a 2-hour infusion every 2 weeks. During which time he would do well and then flare and then have to go on prednisone for the really bad flares. And just when he was coming down off the prednisone and managing the flares, he would have to go back for another infusion. It was a little bit like the story you have with chemotherapy patients, in that they're okay when they go in for therapy, but then therapy induces a storm of activity that is hard to tolerate. And in his case, he had more and more attacks that could only be managed with steroids. So over time, the issue with him was, Doc, how long do I need to take this? And what became apparent was that with each month, his urate deposits got sizably, noticeably smaller. His wife noticed, he had greater mobility. So on one hand, he was delighted. On the other hand, he was dismayed with how long this therapy was going on. It was at 6 months, I told him I needed 6 months more. At 9 months, I told him I needed 6 months more. And then, at some point, when we made a gigantic reduction, like a 90% reduction in his urate, visible urate deposits, then we could consider going on oral urate lowering therapy. Well, he only took therapy for 8 months. And then he was lost to follow-up. And then he died 7 months later. And such is the case of people with really, really bad gout. Patients who I have considered for severe urate lowering therapy and pegloticase therapy, and being very aggressive, often don't want to take the therapy, and when they don't, their outcomes are horrible. Kidney outcomes are bad, heart outcomes are bad, sometimes they die. And that just shows you how complex this total body urate deposition disorder really is. So it takes a short-term plan, a long-term plan. It takes a lot of coaching to get someone through who has Tophi, and needs them to be reduced because uric acid is a bad marker. It's a bad biomarker, and it's the uric. Of course, when you give them a drug like pegloticase, their uric acid levels just go down to zero. They become undetectable. In his case, we put him on a background of azathioprine to suppress an immune response to the pegylated part of pegloticase, which is often immunogenic, and when they develop an anti-drug antibody, makes the drug ineffective and their uric acid levels shoot up, suggesting one, inefficacy, and two, toxicity. So we suppressed that with 100 milligrams azathioprine, and he did very, very well, with the exception of his long-term outcome and his intermittent flares based on uric acid lowering or depletion of his uric acid deposits. So a difficult case. What I learned from this, I think, is that, again, it takes a short-term and a long-term plan. What do you think? More QD videos tomorrow.